Hi, this is Dr. Alissa Willis from the Cleveland Clinic Mellen Center for Multiple Sclerosis. I'd like to share with you some updates from the 2016 European Committee for Treatment and Research in MS annual meeting. The title of my presentation is Progressive MS. Where are we and where do we go from here? The first presentation I would like to discuss was given by Diaz, Cruz, and colleagues from the MS group at Brigham and Women's in Boston. The 2010 revised diagnostic criteria for MS provides standardized definitions for both relapsing remitting and primary progressive multiple sclerosis. The definition of secondary progressive MS as gradual worsening after a relapsing course is more nebulous. What is gradual worsening? For how long should this be present? While this may not seem incredibly important for day-to-day care, this distinction is very relevant in defining a clinical trial population. Diaz, Cruz, and colleagues used a longitudinal database to evaluate several definitions of SPMS based on the lowest included EDSS and screening time. Changes in disability were reviewed for 2 years. Of slightly more than 400 patients, only 15 to 22% had confirmed disability progression. In this group of patients with a confirmed progression, the EDSS was maintained in a majority of patients through the remainder of the observation period, regardless of screening phase duration, relapses during the screening phase, or lowest EDSS. In summary, this study suggests that a screening phase of 12 months may be just as reliable as a longer screening phase in identifying those patients with secondary progressive MS. Still, a more specific definition of SPMS is needed for clinical trial design. There remains no consensus on time period of gradual worsening for definition of SPMS. Let's turn now to factors that may predict the risk of developing secondary progressive MS. Although it seems intuitive that many people with relapsing remitting MS will at some point develop secondary progressive, the risk factors for progression and time to progression remain under investigation. Scalfari and colleagues from London followed a group of early MS patients for a mean of 7 years. In addition to looking at the impact of early relapses on the risk of progression, this group evaluated the extent of focal gray matter damage through measurement of number and volume of cortical lesions as well as cortical thickness. Not surprisingly, patients who had 3 or more relapses were more likely to develop secondary progressive MS and to do so faster than the groups with fewer relapses. It's also not entirely surprising that gray matter involvement was seen early in the disease, as this has been reported by several other groups. However, the change in gray matter involvement seen in the chart was particularly striking for the group of patients with more than 3 relapses. We typically think of MS as a white matter process, but clearly there is more going on than what we can see on traditional imaging. Although not shown here, this group also reported that a larger volume of baseline cortical lesions predicted shorter time to reach the secondary progressive phase. In summary, a high frequency of early attacks and greater extent of baseline focal cortical damage may predict faster evolution of progressive MS. This finding may help us identify patients with relapsing remitting MS who need more aggressive treatment. Speaking of treatment in MS, I'd like to highlight 3 reports of treatment in secondary progressive MS and 1 report of treatment in primary progressive MS. Mitoxantrone remains the only FDA-approved treatment for progressive MS, and its use is limited by toxicity. Other immunotherapies are used to treat SPMS in clinical practice, though we have very limited data to guide their use. On behalf of the MS-based group, Lorscheider and colleagues reported their analysis of a large cohort of treated and untreated patients with secondary progressive multiple sclerosis. This ongoing international longitudinal registry now includes more than 40,000 patient records, making it a very rich source for real-world data. The group here used the database to identify patients treated with various therapies to be matched with SPMS patients on no therapy. Propensity scores were then used to identify subpopulations with similar baseline characteristics. Ultimately, 2 similar groups of 689 patients were identified and followed for a median of 2.1 years. The risk of experiencing 6-month confirmed disability progression, risk of EDSS greater than or equal to 7, and regression of disability were similar between the 2 groups. Although this study showed no difference in disability progression among treated or untreated patients, this does not account for differences that could be seen with individual patients, with specific therapies, or with other measures of disability. The ASCEND group, on the other hand, looked at a very specific medication. You may recall that this Phase 3 study involving natalizumab-naive patients with SPMS for greater than or equal to 2 years and a baseline EDSS score between 3.0 and 6.5 did not meet its primary endpoint. This endpoint was a composite of timed 25-foot walk, EDSS, and 9-hole peg test. A statistically significant effect on upper limb function was observed in the natalizumab-treated cohort. Kapoor and colleagues from the ASCEND trial presented a subgroup analysis to help us understand how patients with different baseline characteristics fared. Overall, the enrolled patient population had a higher level of disability than we often see in these trials, with 63% having a baseline EDSS between 6.0 and 6.5, which typically indicates cane use or bilateral support. Perhaps counterintuitively, the effect on upper extremity function was more evident in the more disabled and less inflammatory subgroups. However, the number of patients with an EDSS less than 5.5 or with recent inflammatory activity, either relapses or gadolinium-enhancing lesions, was quite small. Overall, we can conclude that the positive effects on upper extremity function were observed in all subgroups. Immunotherapy is not the only approach to treatment for progressive multiple sclerosis. Many patients ask about the value of supplements as neuroprotective agents. Small studies with biotin in progressive multiple sclerosis have been a hot topic at several meetings. Dr. Spain and her group from Portland, Oregon investigated the potential benefits of lipoic acid. Lipoic acid is an inexpensive antioxidant that is widely available over the counter and found in trace amounts in foods like spinach and liver. Lipoic acid was proposed as a therapeutic approach to MS several years ago after a promising study in a mouse model of multiple sclerosis. Dr. Spain and her group now present results of a randomized, double-blind pilot study comparing a high dose of lipoic acid to placebo. This was a small study with less than 25 patients completing in each group. GI upset was more common in the lipoic acid group, but still compliance was greater than 80% as determined by pill counts. No significant safety issues were identified. Both the annualized rate of whole brain atrophy and 2-year volume loss were lower for the lipoic acid group than the placebo. No measures of function or quality of life were provided. This is an interesting pilot trial of high-dose lipoic acid. We still need to learn more about its potential effects before making widespread recommendations for lipoic acid supplementation. Finally, I'd like to touch on a clinical trial for primary progressive multiple sclerosis. Oratorio was the Phase 3 randomized placebo-controlled trial of ocrelizumab in PPMS. The primary endpoint of the trial, 12-week confirmed disability progression measured by the EDSS, was met. Professor Montalban and colleagues reported on a post-hoc analysis using a composite endpoint similar to that of the ASCEND trial we discussed earlier. No evidence of progression is a composite endpoint that includes EDSS, 9-hole peg test, and timed 25-foot walk to determine clinical stability. A significant change or progression on the 9-hole peg test or timed 25-foot walk is defined by a change of more than 20%. Ocrelizumab showed a consistent effect on all 3 measures when compared to placebo. In this exploratory analysis, patients receiving ocrelizumab had a 47% relative increase in no evidence of progression when compared to placebo-treated patients. This consistent positive effect of ocrelizumab on disability is very encouraging. We have yet to understand which baseline patient characteristics are most predictive of clinical stability on this medication. As you can see, progressive MS is an increasingly active area of research. We have work to do in clearly defining patients with SPMS, in determining factors that predict progression, and in evaluating treatment strategies for both secondary progressive and primary progressive MS. Thank you very much for joining me in this update on progressive MS.